Assalamu alaikum. I'd like to thank the organizing committee for giving me this opportunity to present plasma exchange in autoimmune encephalitis. And before we go into the specifics of this therapy, I'd like to shed some light on the definition of autoimmune encephalitis and the pathogenesis in order to understand the rationale behind this therapy. So autoimmune encephalitis is an increasingly recognized etiology of acute neuropsychiatric decline in adults and children. And the clinical manifestation of autoimmune encephalitis are really broad, and that can range from seizures, movement disorder, behavioral changes, cognitive decline, altered level of consciousness. And recently, there is a proposed diagnostic criteria that provide a framework for making the diagnosis of autoimmune encephalitis. However, the sustainable variability in presenting symptoms and the severity, progression of the disease within or across subtypes of autoimmune encephalitis makes the diagnosis challenging occasionally. So the criteria for possible autoimmune encephalitis, you need to have three criteria to be fulfilled. The first criteria is the subacute onset. And subacute onset, it means the symptoms should be before 3 months of presentation, and the symptoms can be anything from change in the memory or altered mental status, and with that can be altered level of consciousness or lethargy or just behavioral and personality changes and psychiatric symptoms. So this is one of the criteria that need to be there. The second criteria as well that's important is you need to have more than one of the following. You need to have focal CNS finding, seizure, and the seizure should not be explained by previously known history of seizure disorder, CSF polycytosis, and that's to say when you have WBCs in the CSF more than 5 per microliter, MRI suggestive encephalitis. So once you have more than one of those, you can fulfill the second criteria. The third criteria is just reasonable exclusion for alternative causes. So basically, you don't need to have any, you should not have any explanation for the above patient symptoms. Pathogenesis of autoimmune encephalitis. Autoimmune encephalitis, it's thought to be to get started as an immune response that's triggered by infection or a neoplasm or environmental trigger, and that reaction usually result in cascade of autoimmune process, and that target the brain. The immune reaction can be variable. It could be cell-mediated, or it could be antibody-mediated, or it could be both. And that result in the spectrum of neurologic and psychiatric manifestation that we see in autoimmune encephalitis. So historically, the paraneoplastic condition was primarily an adult diagnosis. And the discovery of immune-mediated antibody in those paraneoplastic condition and autoimmune encephalitis was basically the origin of the description of the autoimmune encephalitis. So for cases, for example, paraneoplastic condition, for example, associated with anti-Hu antibody, those classic antibody, they were not pathogenic themselves. They were as a result of cell-mediated immunity against a neoplasm, and it just happens that they cross the brain and they can affect the brain, but basically they are not pathogenic themselves. And then this phenomenon allow us to discover the antibodies that's now described in autoimmune encephalitis, that's pathogenic antibody which target the brain surface receptor, for example, an anti-NMDA receptor. Encephalitis, the antibody itself is pathogenic and it targets the brain cells, and that allow us basically to discover those conditions. And this is the framework for therapeutic approach for autoimmune encephalitis, and we'll come to that in the subsequent slides. So in this cartoon here, this is one of the recently described proposed pathogenesis for anti-NMDA encephalitis. As you can see here, the antigen and the antibodies that's secreted by affected neurons that's either infected with a virus or any environmental trigger, those antigen antigen will be processed by antigen presenting cells, and antigen presenting cells they usually go to a lymph node, and that will trigger an inflammatory response, an immune response against the anti-NMDA receptor antibody, will create memory B cells and then mature plasma cells. Those mature plasma cells that secrete anti-NMDA receptor antibody can circulate in the blood, and then they can go to the brain. And when they go to the brain, they affect the synapses or extra synapses, neurons. And in those, when they affect, as we said earlier, those antibodies, they are pathogenic by themselves. So when they affect the receptor, the glutamate subunit receptor of the anti-NMDA receptor, they can either block those receptors and result in neuronal death, or they can open those receptors and create or promote more excitotoxicity, and that will result in seizures and hyperexcitability. So the effect of those antibody is pathogenic, and the fact that they bound to surface receptors make them amenable to immunotherapy, and plasma exchange here play an important role in the removal of those antibodies. Okay, so we've already explained that those antibodies, they are pathogenic themselves, and that's what makes them amenable to immunotherapy. It's very important here to note that chronically inflamed brain is more likely to sustain injury. So as long as those inflammation is ongoing and chronic, there will be more injury sustained, and long-term damage is expected in those individuals, and that's highlight the importance of early treatment and early immunotherapy and prompt escalation of the therapy if the children are not responding to initial treatment. The recent epidemiological study suggests that autoimmune encephalitis is possibly as common as infectious encephalitis, with an estimated prevalence rate of 13.7 in 100,000. And I think everybody noticed these days that we're seeing more and more of cases of autoimmune encephalitis, maybe because we are recognizing those more, maybe there is changes in the environment, who knows, but I'm sure everybody will agree that we're seeing more and more of those cases, and that warrant really particular attention to those cases. So regarding classification for autoimmune encephalitis, there are different classification modality. Some classification, they will use anatomical classification, and that's depend on the site of involvement, whether we have limbic structure or cortical, whether we have basal ganglia, brainstem, cerebellar, and other classification will depend on serological, which is to depend on the antibody, whether we have antibodies to intracellular antigen, the classical or onconeuronal antibody, or antibody to surface antigen like anti-NMDR and anti-LGI1. So that's depend on serology. And then you have etiological classification, which is to say depends on the etiology, whether we are dealing with idiopathic or paraneoplastic or both infectious. And this imaging here just show you the area of involvement in the different anatomic sites of autoimmune encephalitis. So we have the limbic, where it involves the mesial temporal lobe and the limbic structure. And then we have the cortical, subcortical encephalitis. We have here striatal, we have involvement of caudate and putamen. And then we have here the diencephalic encephalitis and the brainstem, and as you can see here, and the pontine involvement, and you can hear meningoencephalitic. So they are different anatomic sites for autoimmune encephalitis. Now we're gonna move on into management of autoimmune encephalitis. Where are we in terms of management of autoimmune encephalitis? So unfortunately, the guidelines for immunotherapy management is lacking, and there is no really large scale controlled prospective trial have been conducted to determine the efficacy of a treatment of autoimmune encephalitis, and that's particularly due to the heterogeneity of autoimmune encephalitis presentation and findings on ancillary testing, and that really hinder large-scale clinical trials and limit the quality of evidence behind autoimmune encephalitis management. So at the present, most of the treatment rely on the understanding of disease mechanism, expert opinion, based on the clinical experience and case series. And when considering acute immunotherapy option, it's important to consider several patient factors. Among that, the time of onset of the presentation from the beginning of the disease onset, as well as serology. If you have positive antibody, that might alter as well your management and comorbidities. All that can take into account. And it's very important to mention here that delay in therapy initiation could worsen outcome, and you don't really need to wait to have the antibody, intraneuronal antibody testing to come positive to initiate a treatment. Once you suspect you are dealing with autoimmune encephalitis, you should initiate a treatment, because the outcome can differ markedly whether you start the treatment early or when you delay treatment. So in this study here that was published in Lancet Neurology 2013, they studied a large number of patients, and 204 patients. They got a 24 months follow-up for those patients, and the outcome they have noticed that continued to improve for 18 months after the symptom onset for anti-NMDA receptor encephalitis. So this is in children. The predictors for good outcome found is the early treatment. So early treatment really changed the outcome of the disease, and the lack of ICU admission was another predictor for good outcome. So coming to the therapies that is used in autoimmune encephalitis, it has been described that we have first-line therapy, and then we have a second-line therapy. First-line therapy is generally used pulse steroid that can be used for 3 to 5 days. IVIG in general, it can be given 2 grams per kilo. It can be given over 2 days or over 5 days. It depends on the protocol that you use in your hospital. And plasma exchange as well is considered one of the first-line therapy. Second-line therapy, we're talking about rituximab and cyclophosphamide. So due to the lack of guideline, there is a group of Autoimmune Encephalitis Alliance Clinician Network. This is a group of neurologists, neuroimmunologists, psychiatrists, and there are more than 68 physicians in this group from 17 countries. And there has been a paper published, proposed best practice recommendation for diagnosis and management for autoimmune encephalitis, and there was an electronic survey that has been sent to those clinicians, and the respondents rate was around 84% of them, and they agreed that their first-line therapy, they used steroid plus minus IVIG or plasma pheresis. So it's either in combination from the get-go, steroid and IVIG, or plasma exchange. So that's the common first-line therapy. Regarding second-line therapy, which we talk about rituximab or cyclophosphamide, 50% of the responder, they used the second line if there is no improvement after using more than one first-line agent. And 32% of the respondents, they mentioned that they will go to second line if there is no response in one first-line agent, then they will immediately go to second line. 15% of the respondents mentioned that they will use second line in all patients. So see, there is variable response regarding which agents they will use and the timing that to be used. But in general, the literature, as I mentioned now, they're suggesting more of early use and more aggressive treatment, especially if there is lack of improvement, and lots of literature describing the use of second-line agent even in after 10 or 14 days from the beginning of the symptoms if there is no improvement with the first-line agent. So plasma exchange, which is the primary subject in our talk, it's basically just involve removal and replacement of host plasma and then you replace it with the human albumin or fresh frozen plasma. And this therapy usually can be effective adjunctive therapy in combination with the steroid and or IVIG. And there are some retrospective study that showed plasma exchange when it was used with a steroid, it provides significant improvement in modified Rankin scale in comparison with the steroid alone. Plasma exchange as well has been found to be more effective in patients with autoimmune encephalitis related to antibodies targeted against surface receptor antibody more than intracellular antigen. And that makes sense because with the mechanism plasma exchange, you basically remove antibodies that's available, that's free in the plasma, and those the antibodies that target the surface antigen, while the intracellular antigen that's hard to be removed, and that makes sense in terms of the mechanism of action. So basically this cartoon here is just simple one showing you the plasma exchange. So basically you need a good central line and you need to have good setup. So if your hospital do not have a good setup for plasma exchange, then that can be a problematic because you really need to have good line. You need to have the facility. If you have dialysis unit, they can help you with the apheresis. So you need to have good setup before starting it. So basically the blood will be removed from the patient and it will go into the apheresis machine, and that will separate the plasma from the plasma of the patient from the cellular content of the blood. So plasma will be discarded, and then the cellular content, packed RBCs, and will be the red blood cells will go back into the patient, and then you replace the fluid with human albumin or fresh frozen plasma if you have a deficient clotting factor. So this is as simple as that. How it works, you need at least 5 sessions. So usual sessions, it's in general from 5 to 7 sessions. It can be stretched to 10, and lots of people, they do it every other day. There are some protocol where they do it daily, and You should keep in mind when you use it and then you want to give rituximab, you should allow some time before doing the plasma exchange if the patient just received rituximab. Some protocols, they recommend up to 5 days. If you have given rituximab, then you start plasma exchange because you don't want to remove it from the system. So plasma exchange work not only by just removing those antibodies, it does have immunomodulatory effect, and that's through other mechanisms as well. And it has been described as it changed the lymphocyte number and their distribution, T suppressor cell function, and T helper cell phenotype. It can increase the proliferation of antibodies producing cells, and that will increase their susceptibility to immunosuppressant medication. We need to understand as well, a plasma exchange does not remove antibody from CSF unless the blood-brain barrier is severely damaged. However, we postulate that once we remove the systemic antibody from plasma, that might decrease the CSF antibody level. Regarding the plasma exchange outcome, there are some publications regarding the outcomes, a recent outcome regarding the clinical efficacy of plasma exchange in patients with autoimmune encephalitis. In those cases, they were severe refractory anti-NMDA receptor encephalitis. In those group, they included 40 patients and 20 patients to each arm. Some patients received therapeutic plasma exchange, and the other patient did not receive, and they checked into the outcome, the improvement in their clinical outcome after 1 month, 2 months, and then after 6 and 12 months. And in those studies, they have noticed that there was remarkable improvement in the group who received the plasma exchange clinically, as well as in their antibody titers in the first and second month of the treatment. However, the 6 months and after 6 months and 12 months, there was no significant difference in the treatment outcome. Regarding IVIG, so there is no really head-to-head comparative study between IVIG and between plasma exchange. There is a clinical trial by the Oxford group in UK. It has been started in 2016. Still, we don't have a result yet. And with that, they are using immunoglobulin, the treatment of encephalitis, and it's a multi-center randomized controlled trial. In this study, they are including different forms of encephalitis, autoimmune versus infectious, and we're still waiting for a result from that study. So it's very important to keep in mind the side effects of those therapies, and especially when counseling patients about their use. IVIG is widely available. It can be used in so many places. You don't need to have set up as plasma exchange for it. And the common side effect, as you know, chemical meningitis, the hyperviscosity and thrombotic syndrome, and non-specific symptom of headache, chest pain, flushing, and fevers, myalgia. Plasma exchange, you can have Lyme-related issues, hypotension from volume depletion, arrhythmias, though this is rare, but monitoring electrolyte pre and post plasma exchange is important. There is some publication about immune absorption, and though this is not widely available because this technology is not available in so many countries, even US, I don't have experience with that, but I just wanted to highlight it. It could be something that's on the horizon in the future. So it's very similar to plasma exchange. So this is what plasma exchange, and here is the immune adsorption. Just the difference is when you remove the plasma, you add here some ligands that bind to the immunoglobulin or the antibody of the patient, and then you can remove those complexes and you return the plasma for the patient, and the plasma will be depleted of immunoglobulin. So with this, you do not lose the clotting factor as what happens in a plasma exchange, for example. There are small studies that they are recommending that immunoadsorption is as effective as plasma exchange in a small series in treating autoimmune encephalitis. So as I mentioned, that this could be something that's coming up in the future because it's more targeted toward the antibodies, more specific. Okay, so coming up to the clinical presentations of autoimmune encephalitis that require ICU care, it's in general patient with altered mental status that require intubation respiratory support, and some patient with autoimmune encephalitis with status epilepticus or super refractory status epilepticus will require ICU, sometimes just severe hyperkinetic movement disorder or autonomic dysfunction will require ICU, and increased ICP can be one of the complications of autoimmune encephalitis, and respiratory failure, of course, is one of the other common indication for ICU care. Regarding prognosis in ICU-treated patients, factors associated with poor neurologic outcomes due to delay in administering immunotherapy, longer ICU state, and the need for mechanical ventilation. If there is as well associated comorbidities and severe sepsis, the need for tracheostomy and malignancy, all those were factors associated with poor neurologic outcome in patients with autoimmune encephalitis that required ICU admission. The mortality rate of ICU admitted patients among those patients ranged between 12% to 40%, but this figure is obtained from adult data, not from pediatric. The main causes of death that have been identified is severe pneumonia, multi-organ dysfunction syndrome, and refractory status epilepticus. So that's everything. Thanks for listening. If you have any question, please let me know.